Hi, everyone. Thank you so much for joining me on this webinar, and apologies for earlier today. I just want to thank the Canadian Public Health Association for inviting me to speak a bit about my postdoctoral data. And today the presentation is called Barriers to Legal Cannabis Access, the Emergence of Community-Based Cannabis Distribution Programs in Vancouver, Canada. And my name is Jenna Valeriani. Just a very quick declaration that I currently work for a company called Canopy Growth, which is a legal cannabis producer, as the Director of Patient Advocacy. But this data that I'm presenting today was collected, and the manuscript was both written and submitted during my postdoctoral fellowship at UBC and the BC Centre on Substance Use, which was before I took on this new role in January 2020. So today I want to do a few things. I want to talk about what these community-based distribution initiatives are, what their utility and their intent are, and really talk a little bit about what we know about cannabis's potential as a harm reduction tool. I want to draw on some completed interviews with people who use drugs in the downtown east side of Vancouver to really examine their reasons for accessing from these sites, what they feel is being addressed through these programs, and really also to think about more about how they report using cannabis in their day-to-day lives. And I also want to tie this to a critical but kind of less talked about aspect of legalization here in Canada, which is, barriers to legal access for people who use drugs. So I think a lot of questions remain about cannabis's potential instrumental uses at all levels of investigation, but really less work to date has truly engaged with people who use drugs in real world contexts, including, what their reported access looks like, what, their instrumental uses of cannabis look like in relation to other drug use. So, to kind of start from the beginning, I think it's important to really talk about, what are cannabis distribution programs? And they actually exist in quite a few cities. We see them in Vancouver, Victoria, and Halifax, as well as a few others. And really at the core, they're kind of these grassroots community-based programs. They're often run by volunteers. And what they do is actually distribute donated illicit cannabis products for free or at very low cost to community members. Each of these programs use slightly different models in terms of how they actually distribute cannabis, but they are all focused on providing cannabis access for very intentional or instrumental uses. The intention here that really underpins these programs is the idea around using cannabis to reduce, manage, or eliminate other drug use. And with the constraints of legal access, not only have these programs in the downtown east side been around for quite a while now, they really continue to grow. And when I talk about cannabis substitution, which I might use that term a few more times throughout this presentation, and again, really tied to the intent of these cannabis substitution programs, I typically lean on Amanda Raymond's definition, which is the conscious use of one drug instead of or in conjunction with another in an effort to reduce negative outcomes. And really, I think research over the years, as early as the 1970s, has pointed to cannabis's potential utility to, manage, reduce, and even eliminate other drugs alongside the high incidence of overdose in Canada and the US. And I think that, given kind of the high incidence of overdose, really has renewed interest in the implication on substitution and on drug use patterns. I think if folks are familiar with the medical cannabis literature, for example, it has long pointed to what sometimes might be called the opioid sparing effect and a few other names that, basically kind of get at the same idea. And I think this is becoming even more, a topic of conversation alongside the high incidence of overdose because cannabis policies are being reformed, all across North America in particular. And at the population level, we see a lot of studies actually investigate the impact of these changing regulations on opioid use and overdose. But certainly this is something that continues to be debated and discussed in the literature. But also, I think it's important to kind of redirect attention back at the individual level and that, still at the individual level, And while the impact of cannabis access in the context of the overdose crisis may leave many unanswered questions, individual level data suggests that, cannabis may hold potential as an adjunct or perhaps an alternative intervention for reducing the frequency of and the harms associated with drug use, particularly when we think about balancing cannabis's safety profile in comparison to other unregulated and increasingly fentanyl adulterated illicit drugs. And again, this really being the key idea that underpins these cannabis distribution programs. And some recent Canadian studies from the BCCSU have suggested that, cannabis use may hold potential to decrease illicit opioid use. It may decrease rates of injection initiation among both street-involved youth and adults. It may decrease the frequency of crack use. So I think that is something I'd want to pause on for a moment, just as we know, interventions for, harmful stimulant use are kind of lacking. So I think that's particularly an area that may hold some potential. And of course, finally, the increased retention in treatment for harmful substance use. So just so we're all on the same page, I thought we could pause a moment and just really have a quick review of what legal cannabis access looks like here in Canada. Of course, the Cannabis Act is the federal regulatory framework that controls the production, the distribution, sale, and possession of cannabis in Canada. And there are two streams of access, both medical and non-medical, or as some people call it, recreational. To flip first to the medical cannabis access, this is a stream of access that has really existed here in Canada since 2001. This is a program that is largely patient and patient advocate fought and led, and with many key court cases throughout the years that have greatly improved access. It wasn't until 2014 that the federal government decided to shift to a commercial market model. And really what we saw was medical cannabis programs shifting from one government contracted producer, although at the time, most patients were accessing outside of that system, to a system where we had many different producers and many different cultivars and many different products. So how it basically works in the medical avenue is a patient would get an authorization from a healthcare provider. Authorization is akin to a prescription. They submit it directly to the producer of their choice, and then they make their orders online or on the phone directly, and it's sent in the mail to the patient. Patients can also get an authorization to grow their medical cannabis, as well as designate somebody to grow for them. If we flip to non-medical or recreational cannabis access, this is probably something most people are very familiar with. It was introduced in October 2018, and it includes all the controls that you'd expect, around the regulation, the production, the distribution, and sale of non-medical cannabis. While I won't get into the fine-grained details, it's just, important to know that every province has its own distribution model, really similar to how we treat alcohol, for example, in Canada. Some are private, some are government run, and some are a mix of both. Access points are generally legal brick and mortar retail stores, as well as online avenues. And people can grow up to 4 plants in most provinces. This certainly excludes Manitoba. In most provinces, also just an important note that in most provinces, governments are typically the wholesale distributor and regulator. So that's something that maybe might come up as we theorize what legal access can look like for these folks. So let's talk about the programs themselves. In our study, we focused on 2 community-based cannabis distribution programs. These were 2 of the biggest in Vancouver. They were definitely the most well-known. And really now, to date, it would be almost 4 years ago when these innovative and free cannabis distribution programs began to emerge. This includes a program called High Hopes, and High Hopes is run by the team at the Overdose Prevention Society. And this program involves some very basic registration, and then access on a per needs basis. So simply a person would go to OPS, they would connect with one of the program managers, and they would be able to get, a handful of whatever was available. The second is a free distribution program organized by a cannabis activist, Neil Magnuson, who's in that photo, and in a collaboration with the Vancouver Area Network of Drug Users, or VANDU. And this program operates twice per week and hands out what they called cannabis care packs to a first come, first serve lineup. So when I left, on the days that they were distributing cannabis, they were averaging serving about 250 to 300 people per day. After the study, which perhaps we can talk about more at another time, they moved from Vandu to a storefront, subsequently were evicted, and now they're operating out of an RV and currently trying to get an exemption from Health Canada. Both of these programs, however, run off of donations of illicit cannabis products. Sometimes they are homemade goods. Sometimes they're products you would have commonly seen packaged and sold in illicit cannabis dispensaries. And really for us, we were interested in looking more closely at how cannabis was being used by people who use drugs by really centralizing their perspectives regarding the use of cannabis. And we really wanted to examine how these community-based cannabis distribution initiatives influence both access and feasibility of cannabis as a harm reduction tool. So to do this, we conducted 23 in-depth qualitative interviews with people who use drugs. And we recruited them from these two sites with the help of some of the key leaders who run these programs. In order to be included in the study, they had to have been using cannabis quite regularly, at least 3 times per week. They had to have been using other street drugs regularly in the last year, and they had to have accessed from a cannabis substitution site over the last 6 months. I also did about 100 hours of ethnographic fieldwork twice per week at the 2 sites in Vancouver. Really just a fancy way to say I did a lot of volunteering and hanging out and speaking to both people who volunteered there as well as people who were going through to kind of contextualize and understand, what we were hearing through our in-depth interviews. I think it's also really important to focus on the context for just a moment. The study was conducted in 2018 and 2019, and it really is just a snapshot in time. Interviews and fieldwork were done 1 to 6 months after legalization went into effect in 2018. And so I think that's important to really think about, because this was a time when things certainly were a little bit more rocky in terms of implementation. Prices were a lot higher per gram, quality was lower, availability was not consistent. The rollout was also slow in terms of points of access. So for example, it took a little bit of time for there to be brick and mortar stores. And at that time, only cannabis flower and oils were available. And then alongside that, of course, we had a well-established kind of medical program. And then alongside that, another really important point is that still at that moment, there were hundreds of illicit cannabis dispensaries, both brick and mortar and online. In Vancouver especially, this was the case. This was the home to many long-standing illicit dispensaries, a handful of which at the time leading up to legalization were given interim business licenses by the city of Vancouver, as long as they were kind of best practice, and with an agreement that they would apply for legal retail licenses when that was available. And really, I think that this was a measure and a move to try to stop the rapid proliferation in Vancouver, where at its peak had, over 500 of these shops. And of course, just thinking about Vancouver and the downtown east side more broadly is home to a lot of these kinds of innovations in community-led harm reduction. For those who are interested, we actually completed the analysis in Vivo 9. We used both deductive and inductive approaches. Our analysis focused on things like perceptions of cannabis access, uptake and feasibility of these programs, financial affordability, the role these programs were playing in people's access. We developed a coding framework and drawing on categories extracted from the interview guide to assist with our analysis. Our research team, coded a few interviews. We came together to discuss emerging themes. We developed a coding framework, and then interviews were coded independently by team members. And just to give you some background on our participants, the mean age was about 47 years old, but respondents ranged pretty widely from 21 to 65 years old. Gender is split almost evenly down the middle. Half the respondents identified as white, a quarter identified as Indigenous, and about 12% identified as Black. Before the interview, we also always ask them a few questions around their drug use patterns. And although I don't think it shows it on this chart, I think interesting to note that half of the sample identified as predominantly being current or former opioid users, and the other half stimulant users. And also I would point out that, a majority of this sample had been using cannabis for a very long time. These weren't naive cannabis users at like 10 years or more. And almost all the sample reported using cannabis for pleasure or fun, to help with pain, and as well as to reduce the use of other drugs. A few more things just to know about our participants was they were daily or near daily cannabis users. They were most commonly smoking cannabis, and they told me that they were using around 1 to 3.5 grams per day, but that they actually needed something closer to 3.5 to 5 grams per day, but that was kind of just out of the realm of accessibility. So it was certainly a convenient sample, but I'll still just note that 70% were actively using other drugs. So let's switch over to a bit about the findings. Let's talk a little bit about how these programs were actually perceived by our participants. So many participants expressed and really talked about the ease of access through these programs. This is part of the reason why they said these programs worked in their communities. Although each of the programs operated differently, one on a per needs basis and the other on a more kind of first come, first serve model, they were similar in that there were very few, if any, restrictions on who could access. These programs are currently community-based and peer-run. And also there was no formal registration. There wasn't really any ID checks. There were definitely no healthcare professionals on site, and really no tracking except for, maybe counting the number of participants that went through, or having a general understanding of how much product they would need each week to serve their client base. In this way, accessing these programs had very few barriers, particularly when compared to legal avenues, which many of them did in our discussions. Most agreed that trying to formalize these programs in any way would likely result in many barriers, and they worried that this would serve as a deterrent for many that were currently accessing through these programs. When discussing the importance of not kind of medicalizing these programs or trying to, get them moved into kind of more of a healthcare setting, participants described, in addition to lowest barrier access, a variety of different social functions that these programs played. They felt like it was a place they could go to socialize and learn, and just to have some human contact. So for example, when speaking about the program and low barriers, one guy said to me, well, right now it's presenting an alternative to people, first of all, to stop doing the drugs that harm them the most. And just the availability, the easy access. High Hopes makes it doesn't put up all these barriers through the legal way and the medical way. You have to sign this, bring this, or do that. But High Hopes, it's just, how can we help you? Can we help you? Here you go. So the ease of access is important. And another man kind of echoed these sentiments and said, I'm a people person. I prefer interpersonal relationships. So I like that aspect, right? Hi, how's it going? Have a nice day. I like that kind of stuff. I don't like institutionalized because it takes the humanity or like I said, interpersonal relationships out of the equation. And I think dealing with what we're talking about here, harm reduction, actually, I think that's kind of an important component. And so this was really important because it draws out, that having kind of that low barrier access was critical, and it brought people into the program that may otherwise not access a program like this. But also community is really important to these programs, right? They're places where people are connecting with one another, they're talking, they're learning, and they're providing support without any of the barriers. And finally, people were also really worried about the formalization or even the disappearance of these programs. A lot of people I talked to, I think simultaneously didn't have really great experiences with any kind of, institutional bodies like either healthcare or police. So it made them a bit skeptical of, what legal cannabis would look like and what their access would look like within that. So someone said, I'm worried what would happen to it in the future. That's really what worries me. If I can't afford what I need now, yeah, it's going to suck when the government gets their greedy hands all over it. They'll be like, you have to order it online and there's shipping costs. You need an address, you need a credit card. If you're able to go in the store, is that going to be $10 a gram kind of thing, or 11, and now as high as 15? So I just can't. So this kind of brings it to our next theme or our next point, which is really about affordability. And just to pause for a second, in the top right-hand corner, that's an example of what a cannabis care pack looked like from the Cannabis Substitution Project. So that was the lineup, first come, first serve. And they generally estimated about, maybe $30 to $50 in product given to each person. So really relying on quite a substantial donation to run these programs. So let's switch back to affordability. This is a place where most of our participants reported living in extreme poverty. More than a third of the sample reported being homeless, and many reported being on, disability or social assistance. Many individuals described the programs as greatly improving their access to cannabis because it was provided at no cost. And while people were able to access these programs quite regularly, a lot of people actually needed more cannabis than what they were able to access from these sites. So as a secondary source, most folks would additionally buy from a friend or commonly an illicit cannabis dispensary when needed. And as a point of comparison, at the time, one of the dispensaries that they would use regularly, an average cost per gram was about $5. None of the individuals in our sample, quite frankly, no one that I talked to over the year and a half that I did my postdoc there had ever purchased cannabis legally. And really, I think, not the focus today, not only did it improve access around issues of affordability, but it also improved access to a range of different products. And this is something we talk about a little bit more in the paper, so I'll just touch on it very briefly. Participants often talked about not just the fact that it gave them greater access to cannabis, but that it also gave them access to particular products that they would have otherwise not had access to. And specifically, they would talk about high dose edibles and CBD. CBD products is really interesting, and it was really insightful to hear them talk a little bit about how they were learning about CBD, how they were integrating CBD into their routine. Of course, this often happened kind of inconsistently because of supply, but they often talked a lot about the benefits that they felt they were getting from those products, which were virtually just unaffordable in a dispensary or any other context. High dose edibles was often discussed as a preferred item because of their strength. So when I say high dose edibles, I'm talking at least 50 milligrams, more commonly 100 milligrams per package and above. Generally, those kinds of products that were so high in dose would actually retail from between $15 to $25 per package in an illicit dispensary. So those were just products that, outside of these programs were not available through any other avenues that they were perhaps, subsidizing additional access with. So, affordability was an issue. Of course, these programs provided cannabis were really key to access. For some folks, it was really about subsidizing their total cost of cannabis. And cost obviously can be really limiting, but it also sometimes restricts the quality of cannabis that people can access. And they really did recognize this. So for example, one woman said to me, I can't say I've completely eliminated other drug use because I did a shot some days ago, but it has gotten a lot better now that I have access to weed. I can't always afford to go to the dispensary to get weed. So when I can't afford it, I come to the program, and that helps me out a lot, like quite a lot. Who can afford to buy weed every single day? The decent weed is always more expensive, right? But that's the weed that can actually help me out the most. And so people often talked about really relying on these programs for access. Another woman said to me, if I'm having a day where I'm having a lot of pain, I'll be like, look, can I just please get some gummies? Do you have any gummies? Do you have any joints? If I'm low on cash that week because I've got things to do, I can go to that person and say, look, I don't have much money. Can you help me out? And then she will. If whatever she has in stock, she'll help me out if I go to her and I say that. So, not only are these programs helping folks access, I think it also alludes to, whatever they have in stock, kind of illuminates the inconsistent nature of what they were able to access through these programs because of the reliance on donations. While everyone accessed at one of the substitution programs for free, as I've mentioned, many people also had to perhaps purchase more product than they were able to get from these programs. So another man told me, you know, if I need more weed, I have to buy it, and I have to buy it day by day. Maybe it's $2, sometimes it's $5, sometimes it's 20, because, you know, it's just what I have financially or what I made at the market, to tell you the truth as well, because I have an addiction to crack, right? So a little money here, a little money there, you know what I mean? So I try to budget, and when all is said and done, at least I have my weed to fall back on, to relax me, for my appetite to be normal, and to get my sleep on. So being able to access kind of smaller amounts on a day-to-day basis isn't really as accessible as it could be through a dispensary, through the legal avenue. You know, certainly through non-medical channels, consumers have to purchase at least 1 gram. And, you know, if a retail storefront isn't accessible, they may have to pay for shipping. All of this in the legal space comes with both sales tax and excise tax on top of cost per gram. So, you know, some challenges there for sure in terms of affordability. And really what he's talking about here really kind of leads us to this third point. So this is something that we don't talk about too much in this paper, but I thought could be kind of important to just show you a few quotes and kind of close the loop on why it's so important that we consider these barriers and how those barriers may disrupt kind of these instrumental uses or these benefits that folks are reporting getting from accessing cannabis. And so a lot of people were discussing their intentional use. They told us about how cannabis helped them, but they're largely excluded from, you know, the emerging and developing legal market at the time. Most reported co-occurring conditions that were often, you know, untreated or weren't currently being managed. I think what really sticks out at the forefront is chronic pain, but also appetite and sleep were really, really prominent as well. And many reported actually using many reported its utility as an adjunct therapy, which was really complementary to a range of different efforts that they were enacting to manage or reduce their other drug use. And so, I mean, before I get, you know, I show you some quotes, I think it's important to say this data is, of course, just a snapshot. I can't speak to actual reductions in other drug use. But, you know, people did tell us a lot about how cannabis was helpful when implemented in conjunction with a range of other interventional strategies. And again, this fundamentally underpins why these sites were created in the first place. And, you know, I think it's also something that we're seeing proliferate in North America. You know, some US states, for example, have already included cannabis as part of their opioid use disorder treatment protocols. You know, different states like the state of New Jersey have added opioid use disorder to their list of qualifying conditions for participation in the state's medical cannabis program. So certainly something, you know, an idea that we're seeing become more integrated in different ways into addiction care in North America. So to give you an example, one woman said to me, about the last 2 or 3 weeks I was there at the hospital, I just went on methadone. I was trying to slow down, and by the time I left there, I never looked back. But the methadone didn't always work, so I started smoking weed. At first, I just smoked weed off and on, you know, take it or leave it, right? But I started to depend on it a little bit more for stability, and I started using it more often when I needed it. Many participants suggested that cannabis can alleviate withdrawal symptoms and that cannabis was important to their day-to-day management and stability. This participant reported using cannabis when opioid maintenance doses were actually not high enough to prevent withdrawal and to prevent their cravings. Another participant told me a little bit about how they tapered off of methadone. She said, you know, once I got down to 5 mils of methadone, I coasted on that for 5 weeks. Then I went down to 4 for 4 weeks, 3 for 3 weeks, all the way down to 1. But you skip over 1 because if you don't, you're stuck there for the rest of your life. There was discomfort, yes. A little bit of withdrawals, of course there is. There was some discomfort because it gets into your bones and it hurts, but it's more like having a nasty flu. And cannabis helps with those things. It was my lifeline, it was my relief for those days, and it made it bearable. So these narratives are really suggesting, you know, the potential utility of cannabis as an adjunct therapy, which can help people reduce cravings, you know, deal with the nausea that they're having, the pain that they're having, and other symptoms. And a lot of people used the language quite literally as taking the edge off. And so I think that that's kind of an important piece as well. This could really lead us to think about the potential benefits, you know, to having cannabis more integrated into addiction care for people who use drugs, because so many were often dealing with wider health issues. Like I mentioned, pain, sleep, anxiety, appetite were also reasons they reported using cannabis. And this intersects with a range of structural vulnerabilities that increase their risk of poor health outcomes. Finally, I wanted to show you this next quote. I wanted to highlight something I stopped on earlier in the presentation that has the sample identified as stimulants as their drug of choice. So I really wanted to highlight that also these folks reported cannabis to be helpful to managing or reducing their stimulant use. So for example, one man said to me, "When I quit doing the booze and cocaine, I find what helped me was to keep busy. Keep smoking weed for sure. The weed is a plus. It helps relax you because you get tense. You get waves where you feel like using and you get, oh, I can't. I want to use, but I can't. Well, that weed just kind of brings you down to relax you and helps you to forget about it. It kind of takes the edge off a little. I would smoke more weed in place of it, which helped me sleep too, because your nerves and your mood swings are going crazy, right? So it affected my sleep, and weed, it relaxes you. It helps you sleep." So I wanted to highlight this, just considering evidence-based interventions for the management of stimulant use are lacking, especially when we contrast them to other substances like opioids. But there is a growing narrative around the potential for cannabis to reduce the severity of stimulant use and other related harms. So we're going to stop here for a few minutes because I want to, not just thinking about how cannabis can be integrated as an adjunct therapy or, more generally integrated in kind of the tools that we have in addiction care, because I think that all of that is a very challenging conversation to have, because the first hurdle that I don't think we pay enough attention to is addressing what access to cannabis actually looks like within these models. Across these participants, it was very clear that there continues to be significant and ongoing barriers to legal cannabis access that could really impede its full potential and utility in the legal context, and why these community-based cannabis distribution programs were and continue to be in high demand, and part of the reason why a lot of these folks reported that access as so instrumental to their well-being. I think there are also some really practical questions here about, do the realities of a legal market and some of those inherent barriers that are built into those systems lend themselves to these programs? I thought we could take a minute just to kind of pause on a discussion of how what we talked about today translates into barriers for accessing legal cannabis, particularly for folks who are marginally housed or experiencing homelessness. Generally, of course, we talked a lot about affordability. That's quite straightforward, right? Cost continues to be a very big issue. So of course, I mentioned both having excise tax and sales tax, really increases the cost per gram. But also, I think it is also fair to say that prices have changed, right? Prices have come down. I went online to one of the legal retailers to see, what was the lowest gram that you could purchase in this moment, and it was $3.50, right? That's relatively affordable. But the catch is that those kind of budget or value brands are typically purchased in bigger quantities. So in this case, you could only buy this in 15 or 30 gram packages, thereby making the inaccessibility a bit more nuanced and a bit more tied to quantities. One of the quotes that I showed you earlier really illuminated that it wasn't uncommon at illicit dispensaries for the product to be weighed up in front of you, right? So if there was, an OG Kush that was $7 per gram and you only had $5, that the person serving you could actually just weigh up that exact amount. And so that idea of being able to just bring in whatever money you had that day is not something that translates very well to legal access, particularly, of course, because they're prepackaged. They typically come in 1 gram at least increments. And of course, that also leads to very logistic barriers, which are things like credit cards and banking, especially in the time of COVID, where a lot of purchasing is done online. ID, having ID can also just be a straight up barrier as well to accessing legal cannabis. Of course, if we're talking about online services, again, home addresses for deliveries, really depending on the avenue of access. Another thing that I would encourage folks to think about is product availability and strength. when we think about the legal products available, and in particular, when we think about, using cannabis very intentionally in a harm reduction setting, the legal market caps edibles at about 10 milligrams per package. So, questions around whether or not that would serve this population. And I'm also not saying that to say, no, it wouldn't. I'm actually not sure what the answer is. And I think perhaps more important is, figuring out the hurdles around cost. And then the other pieces I think can follow. And the last thing that I wanted to say, and something I didn't talk about too much here, but I'll make the point anyways, is that the legal cannabis access landscape can be very confusing, not just for these folks, but for folks in general. So I really still continue to see a need for more public education and awareness around what it looks like to actually purchase legal cannabis. Out of curiosity, I've asked my father in the past to see if he could purchase legal cannabis, and we're in Ontario. And I asked him to jump onto the computer and give it a shot. And, he definitely did not end up on the Ontario Cannabis Site store. He ended up on some site like Bud Buddy, or I can't remember what it was called, but I couldn't help but laugh because he couldn't even navigate, what that purchase would actually look like. It's one thing to be able to walk into a retail store, but also quite another when, the online markets, for example, are saturated with illicit cannabis dispensaries in addition to legal avenues. So, I still see a really strong need for a lot more kind of public education around what that looks like. Even though we're 2 years in, I think we can forget about really the building blocks or the foundations, to mapping out what those avenues of access actually look like. So while this research continues to grow, and as it intersects with organizations and groups that are really interested in cannabis's potential as a harm reduction tool, and they're hearing from people that they work with that cannabis is helping them, we really need to have a lens on what compassionate access looks like and how we can do a better job of attending to issues that intersect with poverty, and especially the need to centralize these factors when considering how cannabis can be better integrated into addiction care. I think these are really important for future work examining the utility of cannabis as a harm reduction tool among vulnerable populations in particular. And of course, as I've said over and over again, things have certainly changed and evolved since I collected data. These programs remain a cornerstone of access. They too have evolved, but fundamentally still do the work of bridging access to cannabis in their communities. And some of them have now capped access to only a certain number of participants. But I think the point there being is that they could be serving many more in their communities as well, who are also struggling with finding consistent access. Substitution programs really remain a low barrier kind of critical option for people in the downtown east side. Kind of throwing it back to folks who may be listening to this webinar, what solutions can we come up with? How can we support their scale up and their operations more generally? I think the reality is they continue to put themselves at potential risk of enforcement. And really, I think coupled with the lack of stability and consistency around products, really makes it difficult to consider, how do we make these things work and still ensure that they're low barrier enough to work. And so I'll kind of leave it at that. I do have some references here, but I'll invite you to actually email me if you have any questions, since we won't have a Q&A today. I also want to just acknowledge my co-authors on the paper, Rebecca Hansaw, Riel Kapler, Ricky Blumenthal, Eugenia Socias, MJ Malloy, Thomas Kerr, and my advisor for my postdoc was Dr. Ryan McNeil. And my email address is there, of course. And I really encourage you to email me if you want to ask questions, if you want to jam on these ideas a little bit more. I'm super open to hearing about maybe different programs or different ideas that you might have. And I really look forward to it. So again, I just want to say thank you to the Canadian Public Health Association for the opportunity to share that work with you all today. And I look forward to hearing any questions or comments or feedback. Thank you so much.